acompañamos en los pequeños como en los grandes pasos de tu vida. Tenemos una manera de sentir la vida que compartimos todos. Es querer ser mejores en nuestras vidas y eso trasciende en nuestra profesión. Es una búsqueda, una forma de ser. Es creer en lo que hacemos, mejorar la salud y calidad de vida de las personas. Es una forma de trabajar con pasión, de aprovechar lo mejor de la ciencia para crear medicamentos y productos innovadores. Somos la tranquilidad que siempre va a estar de tu lado. Desde que naces hasta la plenitud de tu vida. Un camino que recorremos juntos haciéndonos más confiables a cada paso. Te acompañamos en tu nacimiento. Estamos con tu familia, tus amigos, tu trabajo y tu profesión. Y esa cercanía es lo que nos reconforta. Somos confianza en nuestros colaboradores. Somos cultura de excelencia y búsqueda de calidad. Pero sobre todo, somos bienestar. Megalabs. Somos bienestar.
Bueno, hola, ¿qué tal? Soy Gustavo Villoldo y esto es CauTV. Hola a todos. Tengo el placer, o tenemos el placer de contar hoy con nosotros con el doctor Boorjian, quien es el jefe de Urología de la MayoClinic. Así, bueno, es un placer tenerlo con nosotros. Okay, thank you very much for being today with us. It's a pleasure for us to having you. I want to ask you about your long experience in conducting clinical trials related with BCG and responsive disease, even when you were so involved in nasopharyngeal for adenovirus. Could you please tell us a little bit about the experience of performing that clinical trial?
Sure. Well, thank you for having me, and it's really an honor to be here. The fun part about the clinical trial was that we were able to see a new medication go from development in the laboratory to phase 1, phase 2, and phase 3 trial. The other unique feature about the development of nadofaragene was that it was done in a partnership between the Society of Urologic Oncology and a pharmaceutical company, which was a very unique thing in the United States. The phase 3 trial was looking at, as you mentioned, patients with BCG unresponsive disease. Primary population of study was those with BCG unresponsive carcinoma in situ. The medication is favorable to patients because it is delivered into the bladder. It's delivered at a dosing frequency of once only every 3 months, so the number of visits for patients is minimized. We found that it was very well tolerated. The majority of adverse events were irritative lower urinary tract symptoms, and we sometimes would utilize a prophylactic medication for patients who would experience bladder spasms, but oftentimes patients were able to have this treatment with really very limited adverse events. And then, as we were able to report in our manuscript, our efficacy outcomes were really promising, with a 53% complete response rate in the group with carcinoma in situ.
Oh, great. Even when in states you have pembrolizumab approved several years ago, a couple of years ago, how do you think about the implementation of, in the urologic world, the utilization of systemic immunotherapy? Do you think that is disadvantageous when you compare with a local treatment?
Yeah, it's been a big question between urologists and medical oncologists. Some of the questions about the pembrolizumab, as you mentioned, it's systemic, so it's given intravenously. The dosing schedule was once every 3 weeks in the trial where it was approved, so that's a lot of burden on patients. Intravenous therapy, every 3-week dosing. We don't have biomarkers to suggest who might or might not respond to it. The toxicities are potentially significant with the immune-related toxicities that all of the checkpoint inhibitors have. These are often older patients who have other medical problems, and so how they would deal with toxicities like those is questionable. And then, of course, in the U.S. as everywhere, there's the issue of cost. And these medications are significantly costly. So those factors have all impacted, I believe, the integration of pembrolizumab into the management for patients with BCG unresponsive disease.
Okay. I think we have time just for one last question.
Sure.
Thinking about this BCG shortage, this problem that you're facing in the U.S. and the the utilization or the high utilization of this sequential combination of Gemdosi. I mean, do you have experience in using Gemdosi? Is there any tip that you can tell us about the use of these drugs?
Yeah, we do. And I think just to your point, this is going to be really where we can impact patients and the health system when BCG is in a shortage by coming up with completely different alternatives. So a lot of credit goes to the group at the University of Iowa who really spearheaded this and led using gemcitabine and docetaxel combination chemotherapy. Their publication recently that compared retrospectively gemcitabine docetaxel to BCG found that fewer patients discontinued treatment with gemcitabine docetaxel and BCG, perhaps indicating it was better tolerated. We are lucky now that we have the Bridge phase 3 randomized trial in the U.S., which is testing head-to-head gemcitabine docetaxel in the upfront setting in patients with high-risk non-muscle invasive disease. So there's a lot of promise that this may be an option going forward, particularly because, as you mentioned, we live in chronic BCG shortages. If we can have a complete alternative, it's going to be a real opportunity for our patients going forward.
Okay, thank you. Great. And you know, I have this like maybe 10,000 question for you to make, but I think we have no time. So I just want to say thank you very much, very kind of you just being with us and sharing of your knowledge or experience. Bueno, este es el final, así que cerramos acá. Fue un placer haber compartido con el Dr. Boorjian esta sesión de CAUTV. Muchísimas gracias.